To get to that level of detail, we're focusing on the gross anatomy, the big picture structures inside that bony fortress of the vertebral canal.
And how their extensions, the nerves, actually pierce through that fortress wall, through the intervertebral foramen.
We'll start at the very top, defining the spinal cord itself, its boundaries, and its unique anchoring system. Then we'll move through those triple-layered meningeal coverings.
And the spaces they create, which are so clinically important.
Absolutely. Before tackling the spinal nerves themselves, their structure, their branching patterns. And we'll finish up with the blood supply, which is surprisingly vulnerable, and what happens when any of this goes wrong.
It's a journey, but it's an essential one.
All right, let's dive in.
So to properly frame this whole discussion, we really have to start with a solid definition of the spinal cord. It's the continuous cylindrical inferior extension of the brainstem.
So it starts right where the brainstem ends.
Precisely. It commences right at the foramen magnum, where it's structurally continuous with the medulla oblongata. But here's the crucial part, as you noted in the source material. It does not occupy the full length of the vertebral column.
Not even close. Right.
Not even close. Its typical inferior boundary is only the upper border of the lower two-thirds of the vertebral column.
So it's this high-grade, really specialized segment, not some full-length cable running the entire length of your spine. What are the actual metrics, the dimensions?
The average total length is actually pretty short, all things considered. It's about 42 to 45 centimeters long in adults.
That's it, for everything it has to do.
That's it. And while that length is fairly fixed, what is profoundly critical for any kind of clinical practice is its termination point, because that exact spot dictates where a clinician can safely access the vertebral canal for things like a spinal tap.
And that termination point, that's the conus medullaris. And this is where it gets really interesting, because as the source material points out, that point changes drastically throughout our development.
It's a huge diagnostic challenge. In adults, we generally cite the L1, L2 vertebral level, so the cord typically ends just above the first or second lumbar vertebra.
But why does it end so high up? That seems counterintuitive.
It's a fantastic question, and the answer is all about differential growth. The bony vertebral column, which comes from mesodermal somites, grows much, much faster in length during fetal development and childhood than the neural tissue of the spinal cord, which is from the ectoderm.
So the bone literally outpaces the nerve tissue.
It does. The cord effectively gets pulled superiorly, or maybe a better way to think about it is that the vertebral column grows down and away past the fixed inferior end of the cord.
Ah, okay. So the vertebral column outraces the cord, and that's what causes those lower nerve roots to have to stretch and descend so steeply to find their exit points.
Exactly. And that descent is a key marker of development. If you look at newborns, the conus medullaris is usually much lower. It's often found at the L3 vertebral level, sometimes even L4.
So it's a gradual process of it riding up?
It's a gradual ascent.
Oh.
In infants under 1 year, it might only have come up slightly to L2. Even in older children, say between 3 and 7, it tends to sit right around that L2, L3 boundary. You have to see it as a continuous process into early adulthood.
And what's really interesting, as the sources suggest, is that even among adults, there's this minor variation based on biological sex. The data indicates that in adult females, the termination point might be just slightly lower than in males.
A small difference, but it highlights why precise anatomical localization, usually with imaging, is so essential. You can't just assume. If you're planning a procedure in that lumbosacral region and you assume an adult cord ends sharply at L1, but you encounter a termination at L2,
you've already got a significant clinical variable on your hands.
a very significant one.
Right.
Now, if the cord is going to function correctly, while the spine is bending, twisting, extending, that 45-centimeter structure has to be rigidly stabilized.
Right. If it could just shift up and down, every movement would put traction on the nerve roots.
It would be catastrophic, massive neurological damage. So this brings us to the crucial anchoring system that prevents this vertical displacement.
It needs its own internal mooring lines, basically. So what are the key structures that are holding the cord taut?
The principal anchor is the filum terminal, and it's critical to note this is not nervous tissue. It's a shimmering, specialized filament made mostly of pia motor and astrocytic glial tissue.
So connective tissue, not functional nerve tissue.
Right. It begins as the filum terminale internum, extending directly from the tapered tip of the conus medullaris. And this section is quite long, it's about 15 centimeters. It remains enclosed within the meningeal coverings, running all the way down to the level of the second sacral vertebra, S2.
I see. So the filum internum is essentially the tail of the cord wrapped in pia, and it's still floating inside the cerebrospinal fluid of the dural sac. It's like a passive mooring line in that fluid environment.
That is the perfect analogy. And at S2, something important happens. The meningeal coverings, specifically the dura and arachnoid, they fuse around that filament. They turn it into the filum terminale externum.
And that's the final anchor.
That's the final anchor. This external section continues its descent. It pierces the meningeal layers entirely and attaches firmly to the periosteum on the back of the coccyx, your tailbone. This final attachment is the ultimate anchor, ensuring the whole central structure is fixed against the bottom of the column, preventing it from migrating upwards.
So the internum part moors the cord inside the sac, and the externum part moors the sac itself to the bone. That handles the vertical stability. So what about side-to-side and rotational movement? How is the cord protected from that?
That job falls to the beautiful and strangely named denticulate ligaments.
Denticulate means small tooth, right?
It's a perfect description. These are paired, lateral, tooth-like sheets or folds of pia mater. They project laterally from the surface of the spinal cord along its entire length. They have roughly 21 of these sharp-pointed attachments that actually penetrate the arachnoid and dura mater to fix the cord laterally.
So it's like internal bracing.
That's precisely what it is, internal bracing. They limit side-to-side displacement and, most critically, rotational forces. The source material emphasizes that surgically, these ligaments are really important landmarks. They define the posterior lateral limits of the cord surface, which is crucial for certain neurosurgical approaches.
Okay, shifting focus from the anchors to the nervous tissue itself, we have to address the cord's profile. Because it's not a single uniform cylinder, is it? It swells dramatically in two specific locations.
Correct, and those enlargements are critical indicators of functional complexity. The cord has to be wider in regions that supply the limbs because it needs a vastly increased number of motor and sensory neurons to handle the density of the upper and lower extremities. These are the two fusiform enlargements.
So the first one, the cervical enlargement, that's the upper hub. Where is it and why is it so big?
It's located approximately from the third cervical vertebra down to the first thoracic vertebra, so C3 to T1. And it's essential because it accommodates all the nervous tissue necessary for the brachial plexus.
The network that supplies the arms.
The entire upper limb, the complex braided network for the shoulder, arm, forearm, and hand. Its functional demand necessitates its impressive size. The source material gives its maximum transverse dimension as about 38 millimeters.
38 millimeters, that's actually quite wide for a structure that's encased in bone. Why does that dimension matter clinically beyond just housing the nerves?
Because that physical dimension dictates the available space within the cervical vertebral canal. The larger the diameter of the nervous tissue, the smaller the protective space around it.
Which means it's more vulnerable.
Exactly. The cervical cord is intrinsically more vulnerable to compression from minor space-occupying lesions, like a small disc herniation or a bone spur, compared to the smaller, more protected thoracic cord. There's just less room for error.
Okay, and then inferiorly we find the lumbosacral enlargement, which is often just called the lumbar enlargement.
This one runs lower, from about the second lumbar segment down to the third sacral segment, so L2 to S3. And it houses the neurons that feed the lumbosacral plexus.
Supplying the lower limbs and pelvis.
Right. And while it's also large, its maximum diameter is measured at about 35 millimeters, so just slightly smaller than its cervical counterpart.
That slight difference, 38 millimeters in the neck versus 35 in the low back, is that just a measurement artifact, or is there a functional reason for that?
Oh, it's absolutely functional. It reflects the functional load and the mechanical necessity. The upper limbs, particularly your hands, require a far greater density of precise motor control and fine discriminative sensation than the legs do.
So more processing power is needed for the hands.
Much more. Therefore, the cervical enlargement is thicker because it houses a higher concentration of these intricate neural circuits. It's the most complex segment of the cord by far.
Okay, so once the nervous tissue has tapered into that conus medullaris at L1, L2, we're left with this fascinating, unique structure that we have to talk about. The cauda equina.
The cauda equina, which is Latin for horse's tail, it's the definitive caudal bundle of nerve roots that descend inferiorly below the end of the conus medullaris. Remember, because of that differential growth, the cord ends high. But the lumbar, sacral, and coccygeal nerves still have to exit their corresponding intervertebral foramina way lower down.
So instead of exiting horizontally, like they mostly do in the neck, these roots are stretched vertically. They form this dense bundle that runs parallel to the filum terminale, all contained within that dural sac.
Precisely. They're long, they're numerous, and they are significantly larger than the roots you'd find in the thoracic spine. They're essentially traveling or floating, as you said earlier, within that CSF reservoir, the dural sac, before they find their progressively lower exit points.
So that distinction between the flexible mobile nerve roots of the cauda equina and the delicate fixed tissue of the spinal cord itself, that must be the most critical anatomical consideration for any procedure in the lower back.
It is the most critical distinction, period.
Let's transition now to the protective environment, which is, it's just as critical as the nervous tissue itself.
Absolutely. The central nervous system requires these three distinct membranes, the dura, the arachnoid, and the pia mater, and the specialized spaces they create. They provide mechanical cushioning, chemical stability, and fluid circulation. It's a whole ecosystem.
We'll start with the outermost fortress wall, the dura mater, which has that great nickname, the tough mother.
And it absolutely embodies that term. The spinal dura mater is a thick, tubular, highly dense, fibrous layer. Its continuity is key. Cranially, it fuses seamlessly with the cranial dura mater and the foramen magnum.
And it extends all the way down to...
All the way down to the second sacral vertebra, S2.
Why S2 specifically? That seems like a really important boundary.
S2 marks the end of the dural sac. Below S2, the dura tapers off, and it blends with the filum terminale internum, creating that filum terminale externum, that final bony anchor we discussed. So S2 is the point where the protection of the CSF-filled space officially concludes.
Now, in terms of its attachment to the bone, is the dura just glued to the vertebral canal?
No, and it's essential that it's not. It's not a rigid attachment everywhere. It's loosely connected to the posterior longitudinal ligament and the periosteum of the vertebral bodies, particularly at the cervical and lumbosacral ends.
And that looseness allows for movement?
Exactly. That laxity allows for flexion and extension of the spine without tearing the dura. However, it does form very tight connections as the nerve roots exit.
Tell us about those connections, because that seems crucial for protecting the nerves.
It is. As the spinal nerve roots travel toward their exit point via the intervertebral foramina, or IVF, the dura mater extends as a sleeve. It encompasses both the dorsal and ventral roots.
So it's like a protective tunnel?
A continuous protective tunnel. It travels outward until it blends and fuses with the epineurium, the tough outer connective tissue wrapping of the spinal nerve itself, just beyond the point where the dorsal root ganglion resides. This continuity provides a sealed, strong pathway for the nerve as it passes through the bony canal exit.
Okay, moving outward from the dura, we hit the first of our critical, clinically vital spaces, the epidural space.
This space is absolutely vital in clinical practice, particularly for pain management. It's the space situated between the dura mater internally and the periosteum that's lining the surrounding vertebral canal externally.
It's often shown as this empty black space on diagrams, but the source material is clear that it is packed with functional structures. What fills this space, and what is its role?
It is packed with contents that are designed for cushioning and drainage. Firstly, it contains loose, yellowish adipose tissue. That's the epidural fat, which is held together by thin fibrous bands.
So, padding.
Yes. This fat provides cushioning and padding, protecting the dural sac from trauma and movement against the rough bony walls. Secondly, and perhaps even more importantly, it houses the extensive valveless internal vertebral venous plexus. Some older texts call it the torquoise venous plexus.
That venous network is a critical structure. Why is it so significant that this plexus lacks valves, especially given its location?
Well, the valveless nature allows for bidirectional blood flow. This means that pressure changes in your abdominal or thoracic cavities, from something as simple as coughing or heavy lifting, can momentarily reverse the blood flow direction within the spine.
And that has some serious implications.
It does. While it's a normal feature, it makes the internal vertebral venous plexus a significant non-caval pathway for the spread of infection, especially from the pelvis. And it's a critical route for the metastasis of cancer cells, like from prostate or breast cancer, directly to the vertebrae and even up to the brain sinuses.
So the fat provides the cushion, and the venous plexus handles drainage, but unfortunately also provides a metastatic bypass. The clinical relevance is obvious. This is the target for epidural injections.
Precisely. The loose adipose tissue and the accessible space allow anesthetic agents to be injected right into that epidural space. These agents then diffuse and they bathe the spinal nerve roots as they pass through, blocking pain signals without necessarily affecting the integrity of the spinal cord or accessing the cerebrospinal fluid.
Understanding the anatomy of that space is key to making it work.
It is key to predicting the spread and effectiveness of the anesthetic.
Okay, now if we move immediately deep to the dura mater, we hit the subdural space. This brings up an important question. Is the subdural space actually a space at all, in the normal sense?
Anatomically speaking, no, it is not a normal space. It's defined as a potential space between the dura mater and the arachnoid mater. In a healthy living body, these two layers are physically stuck together by surface tension and connective tissue bridges.
So it only becomes a real, visible cavity under pathological conditions.
Correct. We only see this space opened up by trauma, disease, or abnormal fluid accumulation, like a spinal subdural hematoma, where a hemorrhage actually separates the layers. For students of anatomy, it's vital to think of it as a location where damage can occur, rather than a necessary anatomical compartment.
Okay, so bypassing that potential space, we come to the arachnoid mater, delicate and non-vascular.
The arachnoid is named for its spiderweb-like structure. It lines the inner surface of the dura and is characterized by these fine connective tissue strands, the arachnoid trabeculae, that traverse the neck space to connect to the pia mater. It acts as the inner lining of the dural sac, and like the dura, it contributes sleeves around the exiting nerve roots.
And between the arachnoid and the pia is the most critical fluid environment, the subarachnoid space.
This is the large essential reservoir for cerebrospinal fluid, or CSF. The entire spinal cord floats in CSF within this space. This provides vital buoyancy. It reduces the cord's effective weight and prevents mechanical distortion, and it provides essential shock absorption against sudden movements or trauma. It also contains the major blood vessels that supply the spinal cord.
And the functional demands of those lower spinal roots require a huge expansion of this space inferiorly, which forms the lumbar cistern.
This is the anatomical gift of that differential growth we talked about. Because the spinal cord terminates high, up at L1, L2, but the dural sac continues all the way down to S2, the subarachnoid space below the conius is vast and expanded. This lumbar cistern contains the cauda equina and the filum terminale internum, but crucially, no dense, easily damaged spinal cord tissue.
And this precise anatomical separation is why a lumbar puncture or a spinal tap is performed below L2. It allows safe access to that CSF reservoir for diagnosis or drug delivery. You're only targeting the mobile, resilient nerve roots of the cauda equina rather than risking an injury to the cord itself.
The positioning is a testament to natural engineering. It separates the vital nervous system from the clinically necessary access point. The difference in risk between an L1, L2 approach versus, say, an L3, L4 or L4, L5 approach is just astronomical.
Okay, finally we reach the innermost layer, the pia mater, and this complex discussion around the intermediate layer that's mentioned in the source.
The pia mater is unique because it's the most adherent and intimate protective layer. It closely invests the surface of the spinal cord and the nerve roots, physically entering into the deepest grooves, like the anterior median fissure. It's made of resilient, collagenous, and elastic fibers and is notably thicker anteriorly, which reinforces the nervous tissue.
What's fascinating here is the discussion in the source material about this intermediate layer, this layer deep to the arachnoid that we might have historically just called trabeculae.
Indeed. It's a recognition of a specialized microarchitecture. This intermediate layer consists primarily of cells derived from the arachnoid, they're referred to as leptomeningeal cells, which form a continuous cellular and collagenous network that surrounds the spinal cord and lines the subarachnoid space. It's far more organized than just a random scaffolding of threads.
So it's not just CSF passing through a web, it's a structural sheet and a dynamic cellular environment. What is the functional significance of these leptomeningeal cells and this specialized layer?
Well, their function is still being fully elucidated, but they are thought to play a major regulatory role. They're involved in maintaining the chemical environment of the CSF and potentially regulating the reabsorption of CSF. Furthermore, they are part of the spinal cord's immunological barrier system.
So in pathological states like chronic inflammation or infection, this layer can become severely altered.
It can. It can form dense sheets of scar tissue.
And that scarring leads directly to conditions like chronic arachnoiditis, where the cord and roots literally stick together, causing this debilitating, persistent pain.
Precisely. It turns the CSF-filled, buoyancy-providing subarachnoid space into a fixed, restricted cavity. Recognizing this intermediate layer means moving beyond seeing the meninges as just three passive protective sheets and instead viewing them as a dynamic, reactive microenvironment.
Okay, now that we've established a protective housing, let's focus on the conduits that pass through it, the spinal nerves.
Yes, we define them segmentally. 31 pairs in total. That's 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. And each nerve begins its journey as 2 functionally distinct roots.
Let's define the information flow based on these 2 roots. What goes where?
Okay, the ventral anterior roots are the efferent pathway. Think E for exit. They are composed exclusively of axons of motor neurons, the somatic efferent fibers, which transmit signals away from the cord to your skeletal muscles.
So all motor commands.
All voluntary motor commands.
Yes.
And crucially, they also carry the preganglionic autonomic fibers, which mediate all the involuntary functions.
Okay, and the dorsal posterior roots are the sensory or afferent pathway.
Correct. Dorsal roots are purely sensory. They're composed entirely of the central processes of sensory neurons, and they transmit all incoming sensory input pain, temperature, touch, proprioception, which are kind of the energy packs for the neuron, are clustered just outside the cord in the dorsal root ganglia.
Now, the path of these roots is perhaps their most vulnerable point. They have to navigate that bony tunnel known as the radicular canal before they can unite.
It is the point of highest mechanical risk, without a doubt. The roots have to travel through the CSF-filled subarachnoid space, then through the intervertebral foramina, the IVF. As they make this journey, they're closely invested by the pia mater, and as they pass through the subarachnoid space, they acquire that progressively thicker sleeve from the arachnoid, and critically, the dura mater.
And that dural sleeve seems to be the main point of contention in most compressive pathologies.
Absolutely. The dural sleeve tightly surrounds the nerve roots all the way up to the dorsal root ganglion, lateral to the DRG, this covering transitions, blending seamlessly with the perineurium and epineurium of the spinal nerve trunk. The anatomical implication here is that the nerve roots, encased in pia and dura, are incredibly vulnerable to compressive forces in the relatively tight space of that radicular canal.
So herniated disc, a bone spur, an osteophyte, or even just localized inflammation within that rigid dural sleeve can put enormous pressure on the delicate nervous tissue and the DRG.
And the compression isn't just on the nerve fibers, it often directly targets the DRG itself, which is a concentration of highly sensitive sensory cell bodies. Compression there can cause extremely severe, persistent, radiating pain, the absolute hallmark of a radicular syndrome.
We established earlier that the size and orientation of the roots vary significantly by region because of that differential growth. Let's look closer at the cervical roots.
The cervical roots, especially C5 through C8, are notorious. They travel relatively horizontally, but they are disproportionately thick. The source material highlights a thickness ratio to the cord of about 4.1 in this region.
4:1, that's massive.
It's huge. And the reason for that is the sheer density of upper limb innervation. The functional demand controlling every tiny finger movement, coordinating the shoulder, providing rich sensation, it all requires a huge volume of axons.
So that disproportionate thickness means there's less spare room in the already restrictive cervical foramina.
Exactly. It makes these roots intrinsically more susceptible to compression or even traction injury during something like whiplash or sudden movements.
And conversely, in the lumbar and sacral regions, the roots become substantially larger again, especially the upper sacral roots. But their path changes dramatically.
This is the cauda equina in action. Since the cord terminates high, the roots have to descend vertically for long distances within that dural sac. They're thicker because they're supplying the massive musculature and large sensory fields of the lower extremities.
But because they're floating and relatively mobile,
They can typically tolerate greater movement and less direct compression than the fixed cervical roots, though they are certainly vulnerable as a collective bundle.
so the overall rule is, the higher the nerve root, the more horizontal and fixed its path. The lower the nerve root, the more vertical and mobile its path, but the larger the bundle itself becomes.
That's a very concise summary of the consequences of differential growth. And finally, let's just revisit the spinal ganglia, the DRG. We define them as clusters of sensory nerve cell bodies.
And their typical location is within the intervertebral foramina, inside that tight dural sleeve, making them prime targets for compression.
Precisely. They lie within the dural sleeve, generally just medial to the point where the dura blends with the epineurium. This is their standard vulnerable location. However, we do have to account for the exceptions, particularly with the highest cervical nerves.
The C1 and C2 DRGs. Why do they often defy this standard location?
The DRGs for the first and second cervical nerves are often anomalies. They're frequently located inside the vertebral canal, closer to or actually within the dura mater, rather than residing strictly within the tight confines of the IVF.
And why is that?
It's likely a feature of the highly specialized function and short path length of these specific nerves, particularly C1, which has very few, if any, sensory fibers. Understanding this more proximal location is absolutely essential during high cervical surgery.
Okay, so once the ventral and dorsal roots unite just distal to the DRG, they form that short, mixed spinal nerve trunk. And this trunk barely exists before it just explodes into multiple
It
divisions.
does. It creates this detailed branching system that distributes information across the trunk and the limbs. When we dissect a typical spinal nerve, we're tracking 5 main branches that arise almost immediately: the ventral ramus, the dorsal ramus, the crucial meningeal ramus, and the 2 autonomic connectors, the gray and white rami communicantes.
Let's start with the largest and most functionally expansive branches, the ventral rami, or rami priors.
The ventral rami are generally much, much larger than their dorsal counterparts. Their sheer size reflects their enormous distribution. They supply the skin and the extensive complex muscles of the anterolateral trunk, and critically, all 4 limbs.
So they're the real workhorses.
They are the workhorses of the peripheral nervous system. They intermingle to form the major nerve plexuses, the cervical, brachial, lumbar, and sacral plexuses. Complex coordination and movement from walking to texting, it all relies entirely on the ventral rami.
And in stark contrast, the dorsal rami, or rami posteriors, they handle the posterior territory and are usually smaller.
Much smaller. These run posteriorly and are responsible for the limited but critical innervation of the skin and the deep intrinsic muscles of the back, the muscles that control the posture and segmental movements of the vertebral column itself, like the multifidus and rotators. They rarely form complex plexuses. They tend to stick to a largely segmental distribution pattern.
This is where we need to get into the details. The highly specific regional variations of these dorsal rami, because their specialization dictates how back and head pain presents clinically. Let's start with the cervical region, C1 through C8.
Okay, starting at the very top. The C1 dorsal ramus is called the suboccipital nerve. It is predominantly motor, supplying the small, powerful, deep suboccipital muscles that are responsible for subtle head movements, like the rectus capitis posterior minor and the oblique muscles. Very little sensation here.
Then we hit the massive sensory distribution of C2.
Yes, the C2 dorsal ramus gives rise to the greater occipital nerve. This is an exceptionally large, purely sensory branch that is the major source of cutaneous sensation for the entire scalp and the back of the head. It has a complex course, arching over the inferior oblique muscle before it pierces the surrounding fascia and musculature to ascend to the scalp.
And C3 gives us the third occipital nerve, supplying the skin slightly lower on the back of the neck.
It does. And the critical point the source material stresses is the connection between C2 and C3. They frequently anastomose or form a plexus with the greater occipital nerve. And disorders that affect the dural sleeve or the surrounding muscle tone or local inflammation near these roots, even minor compression, can trigger greater occipital neuralgia.
Which causes that characteristic, debilitating, throbbing pain that radiates over the back of the head.
Exactly. It's often misdiagnosed as just a tension headache, but the anatomical origin is very specific.
Okay, moving down to the thoracic region, T1 to T12, the dorsal rami follow that clear pattern of medial and lateral branches, but their cutaneous function shifts, doesn't it?
It does. In the thoracic area, the medial branches supply the intrinsic muscles closest to the midline, the interspinales, rotators, and multifidus. But crucially, in the upper thoracic region from T1 down about T6, these medial branches continue past the musculature, they cross the spinous process, and they become cutaneous branches, supplying sensation along the back near the midline.
So the medial branches handle skin sensation in the upper back. What about the lateral branches?
The lateral branches supply the muscles farther from the midline, so the iliocostalis and longissimus components of the erector spinae group, and these lateral branches only become cutaneous lower down, generally below the T6 or T7 vertebral level. So as you move inferiorly, the lateral branches take over the majority of the cutaneous supply for the flank and back area. It's a segmental handover of responsibility.
Now, the lumbar dorsal rami, L1 to L5, these are generally larger overall.
Yes, reflecting the increased size of the lower back musculature. The medial branches here are almost exclusively dedicated to the multifidus muscle, the key stabilizer of the lumbar spine. The lateral branches primarily supply the massive erector spinae group. But here's the unique detail. The lateral branches of L1, L2, and L3 travel distally and laterally, often crossing the rigid iliac crest, to supply sensation to the skin over the buttocks.
And that long, traveling cutaneous path explains the pattern of referred pain and numbness that often accompanies high lumbar nerve root issues. It can manifest as pain solely in the hip or buttocks.
Precisely. That specific path means pathology in the upper lumbar spine can easily mimic issues that seem to be originating much lower down. The sacral and coccygeal rami are very small, mostly just dedicated to supplying sensation over the sacrum and coccyx.
Okay, let's synthesize this complex system now into its four core functional components, a reminder of what signals every single spinal nerve carries.
Right. Remember, spinal nerve is a mixed nerve, carrying information both ways. So the four functional components are: 1. Somatic efferent. That's your motor supply for voluntary control of all skeletal muscle.
2. Somatic efferent.
That's your sensory input: touch, pain, temperature from the skin, body wall, and limbs.
Uh,
3 is visceral efferent. That's the involuntary control system, your preganglionic, sympathetic, and parasympathetic outflow. And 4 is visceral efferent.
Sensory input from the organs.
Right? Sensory input like stretch, ischemia, or pain from your internal organs, your viscera.
Okay, let's focus in on the autonomic components, detailing the specific path of the sympathetic fibers.
Preganglionic sympathetic fibers exit the spinal cord only in the thoracolumbar region, specifically from T1 down to about L2 or L3. They're carried initially within the ventral roots, then they pass to the ventral rami, and then they immediately split off to enter the sympathetic trunk via the white rami communicantes.
And the white color comes from the myelin.
Exactly, the myelination of these preganglionic fibers. They then synapse in a ganglion, and the postganglionic fibers have to return to the spinal nerve via the gray rami communicantes.
Why the return path? Why do they have to go back?
The gray rami communicantes, named because the postganglionic fibers are unmyelinated, they provide the distribution pathway. They return to every single spinal nerve, from C1 all the way down to the coccygeal nerve, ensuring that the sympathetic outflow reaches the entire periphery.
So they travel with both the ventral and dorsal rami.
They do, to supply peripheral structures: blood vessels for vasoconstriction, sweat glands for thermoregulation, and erector pili muscles for piloerection. It's the necessary mechanism for widespread regional sympathetic control.
And the parasympathetic outflow is much more confined just to the sacral region.
Correct. The parasympathetic system only exits the cord via ventral roots in the sacral region, S2 through S4. These preganglionic fibers travel through the ventral rami, they form a pelvic splanchnic nerves, and they reach the pelvic viscera to control processes like bladder emptying and erection.
We have one final, crucial branch that links directly to spinal pathology: the meningeal nerves, also known as the recurrent sinovertebral nerves.
These are of immense clinical importance in pain medicine. They arise from the spinal nerve trunk just distal to the union of the roots, or sometimes from the ventral rami or even the gray rami communicantes. They're often dismissed in quick anatomical reviews, but they are the alarm wires of the spine.
And their defining unique path is that they immediately turn around and re-enter the vertebral canal, often communicating with levels above and below their origin.
Yes, they re-enter the protective shell through the intervertebral foramen. They then ascend and descend to innervate structures within the canal that, if damaged, cause deep chronic pain.
So what exactly is their target audience inside that canal?
They supply the pain-sensitive structures,
Mm-hmm.
the dermatod itself, the highly stressed posterior longitudinal ligament, the periosteum of the vertebral bodies, and most critically, the outer one-third of the annulus fibrosus of the intervertebral disc.
This raises a really important question. Given the precise innervation of the disc and that posterior ligament, these nerves must be the primary anatomical mediators of centrally located back pain that originates from an internal disc disruption or ligament irritation, which is separate from the radicular pain caused by root compression.
Absolutely. The pain experienced from a chemically irritated or a physically torn annulus fibrosus or strain on the posterior longitudinal ligament is transmitted directly back to the cord via these recurrent meningeal nerves. This anatomical detail is the foundation for explaining chronic axial back pain that doesn't necessarily radiate down the limb. It's a different kind of pain with a different pathway.
Okay, let's shift now to the vascular supply, the plumbing. The high metabolic rate of this nervous tissue demands an exceptionally rich network.
It does, but despite its density, it remains surprisingly vulnerable because of its segmental nature. The supply relies on 3 major longitudinal arteries that are supplemented by numerous feeder vessels.
Let's define those 3 longitudinal trunk arteries that provide the main sort of cephalocaudal highway for blood flow on the surface of the cord.
Okay, first, the anterior spinal artery, or ASA. This is formed superiorly by the union of branches that originate from the vertebral arteries, which themselves come off the subclavian arteries. The ASA is typically one single vessel running along the anterior median fissure, though the source does note it can often be doubled or paired, particularly in the cervical region, before it unites.
And its functional territory is massive. It supplies 2/3 of the cord.
Correct. The ASA supplies the entire anterior 2/3 of the spinal cord. This encompasses all the ventral gray horns, which are the motor centers, the lateral gray horns, the autonomic centers, and the bulk of the white matter, including the critical descending motor tracts. Functionally, this artery controls almost all of your motor output and much of the ascending pain and temperature sensation.
Okay, second, the posterior spinal arteries, the PSAs.
There are usually 2 PSAs on each side, though they're often described as tortuous and irregular. They arise either from the vertebral arteries or, frequently, from the posterior inferior cerebellar arteries, or PTA. They descend inferiorly along the dorsal root entry zones, and they supply the posterior third of the cord.
Which includes the dorsal gray horns and the posterior white columns.
Right. This is primarily the sensory processing domain vibration, proprioception, and conscious touch.
The crucial, complex anatomical reality here is that these longitudinal arteries are not enough on their own. They have to be continuously supplemented by segmental vessels throughout the cord's length.
This segmentation is the key vulnerability. The longitudinal arteries need constant flow from segmental feeder arteries that enter the vertebral canal through the intervertebral foramina at nearly every level, and they're derived from major arteries like the intercostals, the lumbar, and the lateral sacral arteries.
And we classify these feeders into 2 functionally different types, the small radicular arteries and the large, vital radiculomedullary arteries.
Right. Radicular arteries are small vessels. They follow the nerve roots, they supply the roots and the meninges, but typically they don't reach the cord substance itself. Radiculomedullary arteries, however, are the larger, less numerous vessels that penetrate the dura and arachnoid to actually reach and feed the longitudinal arteries, the ASA and the PSAs.
And these are sparse.
Very sparse. There are only about 6 to 10 anterior radiculomedullary arteries and maybe 10 to 23 posterior ones, feeding that entire 45-centimeter length.
Given that sparsity, one specific anterior radiculomedullary vessel carries the weight of the entire lower spinal cord on its shoulders.
Let's zoom in on the most precarious structure in the entire spinal circulation, the great anterior medullary artery of Adamkiewicz. Sometimes it's just called the artery of Adamkiewicz, or the AMA. This artery is the single dominant source of blood for the distal spinal cord.
And where does this critical artery usually arise from?
Well, it's highly asymmetrical and very variable, but it almost always arises from a left-sided segmental artery in the lower thoracic or upper lumbar region, typically between T9 and L2. The source material specifies that it originates on the left side in approximately 80% of individuals.
That degree of asymmetry is astounding. And this one single vessel supplies what proportion of the cord?
It arches sharply. It has this classic hairpin turn to join the ASA. And then it is responsible for the main blood supply to the entire lower 2/3 of the spinal cord, essentially everything below the mid-thoracic region of T4 or T5.
So you're telling me that interruption of this one artery of Adamkiewicz, say, during an aortic aneurysm repair or some other major procedure that compromises its source artery, results in catastrophic spinal cord ischemia for the entire lower body.
It is the defining bottleneck in spinal circulation. It causes immediate loss of motor function and sensory deficits below the T9 segment. Its recognition is absolutely mandatory for any surgery involving the thoracic aorta.
So once the blood is delivered to the surface, how does it penetrate the nervous tissue to reach the core gray matter?
Now we look at the intramedullary arteries. The anterior spinal artery gives off these crucial penetrating vessels called sulcal arteries or central arteries. These penetrate the cord deep within the anterior median fissure, and they supply the deep central structures, the gray matter, where all the cell bodies are located.
And these are end arteries.
They are functionally end arteries, meaning they have minimal collateral circulation. This makes the gray matter extremely susceptible to localized ischemia.
And what about the white columns on the outside?
The ASA and the PSAs also give rise to a superficial pile arterial plexus on the cord surface. This plexus then sends numerous small perforating branches radially into the surrounding white columns. This network gives the white matter slightly better collateral flow than the central gray matter has.
Let's circle back to the devastating clinical consequences of insufficient blood supply. Spinal cord ischemia. We identified a critical watershed area that is uniquely vulnerable.
The watershed areas are zones of overlapping blood supply that are often the last to receive blood and the first to suffer during periods of low systemic pressure. And the cord is most vulnerable to ischemia in the mid-thoracic region, generally P4 to T8, specifically at the junction where the superior ASA supply meets the inferior ASA supply coming up from the artery of Adamkiewicz.
Okay, so if the ASA supplies two-thirds of the cord, why is this T4-T8 watershed, which is halfway down the cord, still considered primarily an anterior deficit?
That's a critical question, and it clarifies the vascular hierarchy. While the PSAs supply the posterior third, the majority of the tissue, including all motor control, is anterior. Ischemia often happens when systemic blood pressure drops, for instance during shock.
So the flow just runs out of steam.
Exactly. The blood flow arriving via the ASA from the superior vertebral arteries often runs out of pressure around T4, and the inferior flow from the powerful Adam-Kievitz artery often doesn't reach effectively higher than T8. This middle gap is split first, and since the ASA is the highway for that region, the deficit is classified as anterior spinal artery syndrome.
And the clinical presentation of anterior spinal artery syndrome is therefore consistent with that damage pattern.
It is. Damage to the ASA results in loss of function of the anterior two-thirds of the cord. Clinically, this manifests as severe motor deficits, paraplegia or quadriplegia, depending on the level and loss of pain and temperature sensation below the lesion, since those tracts are anterior.
But it spares the posterior column function.
Typically, yes, it spares proprioception, vibration sense, and deep touch, because the PSAs maintain blood flow to the dorsal columns.
Finally, the venous drainage. The system mirrors the arterial supply, but adds that critical clinical link back to the epidural space.
Yes, the venous system is highly redundant. It forms 6 or more longitudinal channels on the surface of the cord within the subarachnoid space. These surface veins collect the blood and drain primarily via numerous radicular veins back into the internal vertebral venous plexus.
And that's the valvulus plexus in the epidural space, which connects cranially to the sinuses and inferiorly to the caval systems.
It is. And this extensive valvulus collateral connection provides a direct route for the spread of metastatic cancer. It allows cells from the prostate, lungs, or pelvis to bypass the filtering mechanisms of the liver and lungs and travel directly to the vertebral bodies or the cranial dura. It's a high-risk anatomical shortcut.
All right, now we leverage this detailed anatomical knowledge to understand the clinical syndromes and localized neurological damage. Our understanding of where the cord ends, where the nerves branch, and how the blood flows it's just indispensable for diagnosis.
It is. Clinically, spinal cord injury, or SCI, is strictly defined based on the functional outcome. Tetraplegia, or quadriplegia, is the impairment or loss of motor and/or sensory function resulting from damage to the cervical segments. It affects all 4 limbs, the trunk, and often respiratory function.
And paraplegia is defined strictly as damage below the cervical spine.
Correct. Paraplegia is impairment or loss of function in the thoracic, lumbar, or sacral segments, sparing the cervical segments. It affects the trunk, the lower limbs, and pelvic organ function, but it preserves upper limb function.
When you're analyzing symptoms, you have to differentiate between damage to a single specific spinal nerve root versus damage to the spinal cord segment itself.
That differentiation is key to localization. A lesion of a single spinal nerve is assessed by mapping the specific myotome, which is the motor output, causing specific muscle weakness or paralysis, or the dermatome, the sensory input, causing sensory loss or pain. A direct lesion of the nerve itself causes loss of sensation in the territory of that nerve's cutaneous branch and motor deficits in the muscles it supplies.
And the clinical complexity is magnified because of that misalignment we discussed earlier. The vertebral column level does not align perfectly with the spinal cord segment level, particularly in the cervical and mid-thoracic regions.
This anatomical disparity turns neurological diagnosis into a demanding puzzle. In the cervical region, the spinal cord segments are always superior to the corresponding vertebral bodies. For example, the C8 nerve root exits below the C7 vertebra, but the C8 cord segment lies high up, roughly opposite the C6 vertebral body.
And lower down, the misalignment is extreme.
It is. A fracture at the L1 vertebral level might actually damage the S4 or S5 cord segments within the conus medullaris. Symptom localization requires meticulous anatomical mapping.
Okay, one specific frustrating injury is spinal cord injury without radiological abnormality CWORA. How can the cord be damaged if the bony protection looks perfectly intact on an X-ray?
CWORA is a challenge because standard X-rays or even CT scans show no fracture, no dislocation, no obvious misalignment. And it's most common in motor vehicle accidents, particularly in children under 8 years old.
Why children specifically? What's the mechanism there?
Children have higher spinal elasticity. Their vertebrae and ligaments are much more resilient and flexible, while the cord tissue itself is relatively fixed and less elastic. So the spine can experience this massive transient hyperflexion or hyperextension, stretching the spinal cord beyond its physiological limits, which can cause contusion, hemorrhage, or even infarction of the cord tissue.
And then the spine just snaps back into place.
It snaps back into alignment, leaving no bony trace, but the neurological damage is done. It necessitates a high clinical suspicion despite clear imaging.
Let's return to pain syndromes, leveraging our knowledge of the RAMI. We need to clearly separate the mechanism of radicular pain from referred pain.
Right. Radicular pain is directly traceable to a disorder that's affecting a specific spinal nerve or its dorsal root ganglion, DRG. The anatomical pressure, usually from a disc herniation or foraminal stenosis, causes the pain signal to be generated at the root itself.
And this pain is sharp, electric, lancinating.
Yes, and it radiates distally along the known distribution path of that nerve, like sciatica, which involves the L4 to S3 roots. It's sharp, targeted pain.
And referred pain is the mislocalization of pain signals.
It is. This involves the complex anatomical blending of visceral afferent fibers, that's sensory input from organs, and somatic afferent fibers, sensory input from the skin or body wall, as they terminate on shared neurons within the spinal cord's posterior gray horns.
So the brain gets confused.
The brain gets confused because it typically interprets signals originating from these shared neurons as coming from the more familiar somatic source, the skin. The visceral pain is felt in a distant, unrelated somatic area.
Give us the classic examples that highlight this shared pathway.
Cardiac pain is the prime example. The visceral afferents from the heart enter the cord at T1 to T4. These segments share central neurons with the somatic afferents of the chest wall and the medial left arm. So the brain interprets the heart pain as originating from the chest or arm, even though the heart tissue itself is painless to the touch.
And diaphragmatic pain referred to the shoulder.
Exactly. Pain from the diaphragm is referred to the shoulder because the phrenic nerve afferents share the C3 to C5 segments with the supraclavicular sensory nerves of the shoulder. It's a fundamental trick of the nervous system based entirely on segmental anatomy.
Okay, finally, let's discuss the two end-of-the-canal syndromes. Conus medullaris syndrome versus cauda equina syndrome. Their anatomical distinction dictates vastly different clinical outcomes and prognosis.
And these two syndromes raise that important question. Is the lesion affecting central nervous tissue, the cord, or peripheral nervous tissue, the nerve roots? The answer dictates the treatment priority.
Starting with the central issue, conus medullaris syndrome.
This results from lesions affecting the distal tip of the cord itself, so segments S3 through S5. Because the injury is to the central nervous tissue, which has an upper motor neuron influence, the clinical presentation involves symmetric saddle anesthesia. Early and usually severe bladder and sphincter dysfunction retention is common.
And motor deficits.
Any motor deficits in the lower limbs are often minor and confined to the very distal foot muscles, and they present relatively late. The causes are typically internal intradural tumors or vascular issues affecting those sulcal arteries.
And the peripheral issue, cauda equina syndrome.
This results from lesions affecting the peripheral nerve roots below the caudicus, usually L2 and below. Because these are peripheral nerves, it's a lower motor neuron injury. The symptoms involve severe, often asymmetrical pain, and early and pronounced motor deficits in the legs, leading quickly to weakness and atrophy.
And bladder and sphincter issues.
They occur, but they're typically less severe and present later than in Conus syndrome. This is the classic presentation of a massive lumbar disc herniation compressing the entire bundle of floating roots.
The prognosis is also very different, right? Since the cauda equina is peripheral nerve tissue, it has a chance for regeneration, whereas the conus medullaris is central nervous tissue.
Absolutely. The cauda nerve roots, being peripheral, have a better intrinsic chance of recovery and regeneration after decompression, provided the treatment is immediate. Damage to the conus medullaris, however, is permanent damage to the central nervous system, meaning the functional loss is usually fixed. That anatomical distinction is life-altering.
We must also address the specific, often congenital anomaly known as tethered cord syndrome.
This is a mechanical tragedy of development. It occurs when the conus medullaris is held abnormally low, typically below the L2 vertebral level, because of a short, thick, or inelastic filum terminal.
So as the child grows and the vertebral column lengthens, that inelastic filum creates traction on the cord tissue.
The cord is literally pulled, taut, and stretched longitudinally. This traction causes progressive neurological damage by compromising blood flow and disrupting axonal transport. The stretching results in a constellation of symptoms that often worsen with growth. chronic lower back and leg pain, progressive weakness in the legs, which often results in foot deformities, and severe chronic urological issues due to sphincter dysfunction.
And surgery is often required.
Surgical untethering is often required to halt the progressive damage.
This has been an incredibly detailed and I think a really critical deep dive into the gross anatomy of the spinal cord and spinal nerves. We've moved far beyond the basic diagrams to explore the structures, their defense systems, and the precise paths they take.
To quickly summarize our key insights, first, the meticulous protective layers. From the essential cushioning and the metastatic pathway found in the epidural space, that valvulus venous plexus, to the specialized cellular microarchitecture of the intermediate layer within the subarachnoid space, which expands into the clinically critical lumbar cistern.
Second, the remarkable specialization of the spinal nerve rami. We saw that the dorsal rami are not uniform at all. They have specialized segmented distributions from the sensory dominance of the C2 greater occipital nerve to the shifting cutaneous supply in the thoracic spine, and that entirely dictates how specific pain patterns like greater occipital neuralgia manifest.
And third, the critical asymmetrical vascular supply. The fact that the anterior spinal artery supplies two-thirds of the cord, yet often relies precariously on a single asymmetrical artery, the artery of Adamkiewicz, typically left-sided and low, creates a dangerous bottleneck. Understanding the resulting T4-T8 watershed area explains why the cord remains so vulnerable to ischemia during major surgery.
And if we connect all this to the bigger picture, the importance of this gross anatomy just cannot be overstated. I mean, understanding the mechanism of differential growth and the resulting high termination of the conus medullaris is the fundamental starting point for all spinal access procedures.
And knowing the anchoring functions of the filum terminale and the precise supply territory of those recurrent meningeal nerves allows us to distinguish between nerve compression and deep axial back pain. The anatomical distinctions we covered, whether it's the 4.1 thickness ratio of the cervical roots or the prognosis difference between conus and cauda equina syndromes, are the difference between solving a neurological puzzle quickly and failing to prevent devastating outcomes. This detailed knowledge is the foundation of critical thinking in neuroanatomy.
You now have the knowledge to appreciate the sheer engineering marvel of the radicular canal, how the nerve roots, protected by dural sleeves, transition from floating in cerebrospinal fluid to being firmly anchored by the epineurium as they exit that restrictive bony column. Given this highly controlled and restricted interface where the nerve root is encased by the dural sleeve inside the foramina, how might changes in CSF pressure or subtle immunological reactions in that confined space trigger chronic severe radicular pain, even without evidence of gross mechanical compression from a disc herniation? You have the anatomical foundation now to explore that fascinating neuroinflammatory question on your own.